Okay, arrhythmias originating in the atrium. So let's get started here. Atrial rhythms, any place the heart, except for fibrous tissue, between the atria and the ventricles is capable of serving as a pacemaker for the heart. So that means there's different places that can be capable of being a pacemaker for the heart. So cardiac fibers in both the atria can bring about depolarization and contraction, just like the SA node. So these would be ectopic sites. So atrial arrhythmias, when one or more ectopic sites are in the atria, begin sending impulses. That's what we're looking at. We have something else besides the SA node causing the impulses. This is usually characterized by an abnormal P wave. So something besides the SA node is located in there and it's causing electrical impulses. That's an ectopic site, and that would show a weird looking P wave. And that's ultimately what we're looking at. So the first one we'll see is premature atrial contraction, or PAC. Premature atrial contraction, an entopic site, is either the right or the left atrium sends an impulse before its time, so that's what makes it a premature. It sends an impulse before it's time for the next impulse to come from the sinus node. This results in a premature atrial contraction. In other words, it'll squeeze before it was ready to squeeze, and the SA did not initiate it. An early or premature depolarization and contraction, or a heartbeat occurring sooner than expected. This is why it's called premature atrial contraction. It's before or sooner than it was expected. This is what you'll see here. The premature, the P wave is much smaller in this picture compared to the P waves in the others. So you'll see the highlighted P wave is much smaller in conduction, and then that caused a very small contraction. Therefore, there's less voltage or with it. It appears as a PQRST complex coming close behind the preceding normal PQRST complex. The P wave of the PAC is different from the P wave of the normal beats because depolarization is originating from an ectopic atrial site. This precedes a different direction than does the S sinus depolarization wave. That's why it looks different. It's from a different site. It's from an ectopic site. The conduction through the ventricles generally remains undisturbed. So something else starts it besides the atria. The ventricles just get the signal and they'll still do their normal thing. So the QRS complexes remain identical. You will not see a difference in the QRS complex. After a PAC, a slight pause is seen before the SA node fires again. The PACs interrupt the regularity of the dominant sinus rhythm. So you'll see this PAC pause afterwards. You'll see a longer pause, and that's what you're seeing in this picture on the slide, is that post PAC pause. See a very tiny P wave here compared to the one on the left, and you'll see a longer interval there. So that's that pause. So it's a interrupt the regularity of the beat. That extra beat causes the SA node to become refractory and to generate the next beat, so it must skip a beat. So it will remain or resume 2 P to P intervals after the last one was normal. So to determine whether a pause is non-compensatory, you need to measure the distance between two normal beats occurring before and after the PAC as indicated by the white bar. Here you see the white bar on the picture. You see one has a longer interval than the other one, so this would be a non-compensatory pause ultimately. So compare this distance to the distance included between 3 consecutive beats. So you want to compare it to 3 consecutive altogether. Compensatory versus non-compensatory pause. If it is non-compensatories, the distances are not equal. In other words, you will see here on the picture, non-compensatory pauses, the distances are not equal. That's a longer pause. It didn't factor in that there was an extra one there, so it just went at its normal way. It didn't compensate for it. Now, when you look at the compensatory pause, the distances are equal. So if the distances are equal, it compensated. Just like when we talked about blood gases, it will compensate, and therefore the distances will look identical. The description of PACs, you'll have a P, Q, or ST right after a normal complex with a different appearing P wave. Remember, the P wave is the bad thing or the ectopic thing here, followed by a pause. This can cause an early beat. Your R to R will be shorter. You'll have a weird looking P wave, but your QRS complexes will not be here. There'll be a normal looking QRS complexes. When you're looking at causes of PACs, one of the number one things here is caffeine. It has to be a lot of caffeine for this. Alcohol, tobacco, fatigue, apprehension, atrial damage. A lot of these things can cause PACs. Remember, PACs are very low on the arrhythmia danger scale, so that's not something usually we worry about a great. So they're essentially benign. So more than 6 PACs per minute. They come very close behind normal beats. They may forewarn the onset of more serious atrial arrhythmias. So we start to see more than 6 in a minute. That's when it might begin to look at things like SVT, A-fib, A-flutter. Those things can come out of this. SVT, A-fib, and A-flutter can easily come out of it if we start to see more than 6 per minute. Treatment of PACs is just to treat the underlying fatigue or apprehension that's causing it. Myocardial depressant drugs like quinidine or propranolol. Quinidine is an antiarrhythmic, and propranolol ends in a lol, so therefore it is a beta blocker, and these should help slow down or reduce the amount of PACs. SVT, this is where we're starting to get into things that can be a little bit more significant on someone. The pacemaker function of the heart is taken over by an ectopic site, either the right or left atrium. So it could be either the right or left atrium. The sinus node is no longer in control of the heart. So this used to be called premature atrial tachycardia, or PAT, was an ancient term for SVT. That means paroxysmal, which means there was sudden occurrence of an atrial tachycardia. The atrial tachycardia caused a sinus tachycardia, so it's used to be called PAT, but now it's just called SVT. So more. I know you guys love history, so there you go. Supraventricular tachycardia. The ectopic atrial site sends out more cardiac impulses at a rate about of 180 times per minute. Remember, we had a sinus tach goes from 100 to 160, and this one will range from 160 to 250. 160 to 250, so that's pretty significant. When we're looking at this, impulses from the ectopic site establish extremely regular atrial ventricular contractions. Paroxysmal means it begins and ends abruptly. So they can go into or out of SVT. They can convert on their own, or they might from us to help convert out of it. Here you see the ancient word PAT as well. All right, that's just, remember, a fancy word for SVT, the ancient word for it. Atrial depolarization, originating from the ectopic location, travels in different directions than a sinus depolarization. So the P waves look weird, right? So this is where you're looking at the P waves. Do you see normal P waves? If you don't see a normal smooth contoured P waves, something else is causing So that's supraventricular. So there's something causing that. That's not the normal SA node. Frequently, the rate of SVT is so rapid that the P wave merges with the T wave preceding the complexes, and you can't clearly see them. So the P's and the T's will each other, and so you may not see a P wave or a T wave that's separate from each other because their heart rate is so fast. So that's a sign that it is an SVT and not a sinus tach. Once the impulse reaches the AV node, its path of conductivity through the ventricles generally remains undisturbed. It has a normal, narrow QRS complex. SVT may continue for a few seconds, minutes, hours, or longer before it converts back to a sinus rhythm. So atrial and ventricular rates are going to be equal. So you're not going to see a difference in atrial and ventricular rate. Usually these are sudden at onset or they'll suddenly stop. There's a weird looking P wave. In other words, it's mixed in with the T wave. In a lot of these cases, the rate will be 150 or 160 to 250. You'll have a normal narrow QRS complex. You'll have a regular R to R interval here. SVT is extremely rapid rates. Usually you'll have hemodynamic consequences, so that means your stroke volume will decrease and as well as your cardiac output will decrease. There's just not enough time for the heart to fill in between each squeeze, and therefore you're not pushing out a lot of blood overall, even though your heart rate, there's not enough time to let blood fill. Vital organs such as the brain are sensitive to decreased blood supply, so this could cause dizziness and fainting, decreased in blood pressure, so they'll be hypotensive, and then they might have an acute congestive heart failure here because their heart muscle may go into fatigue. Causes of SVT: atrial sclerotic heart disease. This is from the medulla vasomotor center, ultimately. You might have a rheumatic heart disease that could cause it. In healthy people, things like emotional stress especially can send someone into it. Fatigue, the good old friend alcohol, coffee, and tobacco, all those staples of adulthood there could easily cause an SVT. That's why grabbing a history on a patient can be very useful when you start to see some of these things. Treatment, when you see it, the first treatment and most benign, most non-invasive way to do it is to have them vagal. So pretend they're bearing down like they're going to the bathroom. They've even done things where they put their face into a little ice bath, things like that, to end a acute episode that causes usually someone to vagal, and that should help take them out of the SVT. In babies, we just put an ice pack next to their face, and that'll cause them to come out of it. Synchronized cardioversion is the next one. We hook them up to a Zoll monitor. Those are those things you put on the patient, and then you press the electricity button. It gives them sort of like the AED pads. This is synchronized though, so that way we don't hit them on the T wave and then cause their heart to stop altogether. So this is why it's called synchronized cardioversion. You don't want to shock them on the T wave and then end up not having the heart have any electrical activity, right? That's the repolarization of the ventricles. If we don't do synchronized cardioversion, we can do drugs, and usually after vagal stimulation, drugs are the second line, and then synchronized cardioversion would be the third thing that we would do. Synchronized cardioversion, the patient has a rapid jolt. If you look up some YouTube videos, you'll see that. So drugs, adenosine is going to be the first one you'll see on here. There's also quinidine and indorol. Quinidine is the antiarrhythmic, and indorol is a beta blocker. So the drugs that you most likely will see is either 6 milligrams of adenosine, and if that doesn't work, we'll do 12 milligrams of adenosine. If that doesn't work, then we'll probably go to synchronized cardiovert. But the big thing here, if we do have to synchronize cardiovert, maybe we try sedation. And the sedation, if it's an stress thing, might actually be sooner on the list for the treatments. So that's SVT. Atrial flutter, when an ectopic site is one of the atria captures the pacemaking function of the heart. Regular atrial depolarization and contractions are established at a rate of 250 to 350 times per minute. That's atrial flutter is ultimately what is produced. So the atrial flutter has a very fast atrial. Now, does that mean the ventricles are going to fire that fast? Absolutely not. The primary difference between SVT and atrial flutter is the atrial rate. Atrial flutter tends to produce a very distinctive EKG pattern. This is where you'll see the sawtooth waves that we talked about in the other presentation. Flutter waves will merge so that they come right after each other with no isoelectric. In other words, it won't come back to baseline. In leads 2, 3, and AVF, you will see this going on. So here you see a ton of P wave, P wave, P wave. These P waves are shark tooth, sawtooth type looking, and that's a classic sign of atrial flutter. That's why you see the shark tooth thing. Atrial depolarizations resemble the teeth of a saw or of a shark, whichever method you want to remember. The sawtooth P waves generally cannot be seen in lead 1. So that is not something you would just see in lead 1. Usually it's in lead 2, 3, and AVF. The AV node is not physiologically capable of transmitting to the ventricles at all impulses that reaches the atrial flutter, so therefore only every second, third, or fourth atrial impulse will get to the ventricles. So all other impulses are stopped at the AV node. So that's why we don't have a really, really fast ventricular rate. It's too fast for it to really transmit. So that's why we'll have a 2 to 1, 3 to 1, 4 to 1 atrial to ventricular here. So the result ultimately, the number of atrial contractions of the ventricular rate is ultimately slower because we have a 2 to 1 than a normal atrial rate. The atrial impulses that do reach the ventricles are usually conducted through the bundle of His, bundle, branches, and Purkinje fibers, producing a normal QRS complexes. So these will be normal, narrow QRS complexes. The conduction ratios, which is what we were talking about just a second ago, the number of atrial contractions occurring in relation to the ventricular contractions determines the conduction ratio of the flutter. I was talking about like every 2, 3, or 4, you will see a QRS complexes. So 2 P waves for every QRS complex would be a 2 to 1 conduction ratio. Ventricular rate is usually half of the atrial rate here. So if their ventricular rate was 60, their heart rate would be 120. Their atrial rate would be 120, right? So that's what you're looking at. It's usually half your atrial rate is. When you're looking at 3 P waves for each QRS complex, this would be a 3 to 1 ratio. Ventricle rate is a third of the atrial rate. So the number of P waves for each QRS continuously changes, and this is a variable conduction ratio that you'll see out there. So a 2 to 1 and a 3 to 1 conduction ratios are the most common. 4 to 1 and a 5 to 1, even 1 to 1 ratios are possible, but you'll probably, most statistics, as far as statistics go, most likely you'll see a 2 to 1 or a 3 to 1 ratio. Unless you're working in an extreme cardiac ICU where you see a lot of interesting cases, you may see more overall. In the atrial flutter, the atrial rhythm is extremely regular. It's very dependable, it's very predictable, it's very regular. If the conduction of the ratio is constant, then the ventricular rhythm will also be regular, so it won't mess up the rhythm of the ventricles either. So if the conduction ratio is variable, the ventricular rhythm will be irregular. So if conduction changes from a 2-to-1 to a 3-to-1 to a 4-to-1 to a 1-to-1, then your ventricular rhythm will be irregular. That's what it's saying. So if the conduction is variable, so will the conduction to the ventricles be variable. Overall, perhaps the most overlooked of all arrhythmias is the 2-to-1 flutter. With every other P wave, is obscured by the QRS complex and may be mistaken as a sinus tachycardia or an SVT. So you might have an A flutter with a rapid ventricular response and it causes a sinus tachycardia or an SVT, or at least looks like a sinus tach or an SVT when it's actually atrial flutter. So the big thing here is to rule out an SVT. Overall, that's one of the biggest things you can do if you suspect it's that. Let's rule out an SVT, which is more serious first. An atrial flutter may increase in conduction ratio, like a 2-to-1 could easily go to a 3-to-1 or a 4-to-1. This should be suspected anytime a regular heart rhythm with a rate of around 150 beats per minute is observed. So that's something that we'll have to look at. Grab a 12 lead and look at our differentials. Description of atrial flutter. The atrial rate will be 250 to 350, pretty fast rate there. You'll have weird looking sawtooth P waves. Not all P waves will get through, so you may not see an isoelectric line because of this odd quivering or weirdness of the P waves, but the QRS, they'll look fine. Causes, this could easily happen after the heart's gone through an injury like a heart attack or a myocardial infarction. Post-cardiac surgery, they caused a lot of trauma. Surgery itself can cause trauma and or injury to the heart or stress on the heart. Accompanying ventricular heart disease, valvular heart disease. So that's a mitral valve is usually one of the more common surgeries that you will see, a mitral valve replacement. So that could easily come along after surgery with those patients. The underlying cause is usually pretty obscure for it. It's more associated with injury, but it's always a direct known there. Atrial flutter, the significance of it depends on the ventricular rate. If the ventricular rate is excessively fast, then their output will be decreased and their stroke volume will be decreased. So if the atrial rate transmits to the ventricles very fast, then they'll have a more serious issue because the cardiac output and their stroke volume will be low. If we don't have a fast ventricular rate, it's not as significant ultimately as emergent, I should say. Treatments of flutter, we have a couple of drugs, DILT or diltiazem, beta blockers, all these will slow down conduction, verapamil, digoxin, once again we've talked about these drugs before, procainamide, quinidine, anticoagulants will work, as well as good old synchronized cardioversion. The synchronized is the key word here. You want to remember because you don't want to shock on a T wave and then cause no electrical activity. Bad move there. Atrial fibrillation and erratic quivering or twitching of the atrial muscle. So this is not as predictable as a flutter. This is a fib. So you just have erratic, crazy, weird moving. And I always remember this because a fib sounds like a lie, right? Atrial fibrillation. It's lying. It's all over the place. You can't predict it. People have to cover up their lies. This has no effect, you do not have effective atrial contraction here. So the atrial kick that shoots blood from the atrium into the ventricle is not as effective as it once was. So that's something that you will lose. All the atrial muscle fibers are independently, those atrial muscle fibers. They're just going all random and crazy. They don't know who to listen to ultimately. That's what causes that weird electrical activity there. So the electrical impulses formed in the atria reach the AV node and are conducted to the ventricles at very irregular intervals. In other words, your ventricle rate will be usually irregular. You'll have 5 boxes in between your R to R, 2 boxes between your R to R, so on and so forth. So usually, unlike a flutter, A-fib creates a weird random rhythm for the ventricles. The sequence of ventricular depolarization and the character of the contraction generally remain normal. So in other words, you'll see a QRS complex, it'll be narrow, but it's just going to be sort of variable ultimately. Only the atria are fibrillating, not the ventricles. So it's just the atrias, the top parts, left to right atrias, are just quivering up there, shaking away like they've had too much albuterol in their system or caffeine. This will create a very chaotic isoelectric line, very chaotic baseline. With normal looking QRS complexes, they'll be narrow, they'll have normal interval for the QRS complex, but they'll come at usually totally irregular intervals. So remember A-fib, irregular intervals for QRS. A-flutter, usually regular. So A-fib, irregular. A-flutter, regular. Causes of A-fib, congestive heart failure, very, very common with this. Number one cause of congestive heart failure is usually hypertension. And then a pulmonary emboli. And remember, pulmonary emboli is usually acute onset. So if someone, if you look at someone's EKG and you suddenly see A-fib and it's not something they've had before, and they've just had a sudden acute desaturation, that might be something you want to look at. Dangers of atrial fibrillation. The big one is going to be clots, and that's why most people with atrial fibrillation will be on an antithrombotic, they'll be on some blood thinners, they'll be on something that stops them from getting clots, because now the movement of blood through the atria can be slower or impeded, and some red blood cells can stay behind and collect and cause a blood clot. So treatment of AFib, once again, DILT or diltiazem, beta blockers, verapamil, digoxin, procainamide, quinidine, anticoagulants, and finally synchronized cardioversion. I would highlight the synchronized part of that because that's very important overall. Remember, we don't want to hit an electrical we don't want to give them an electrical impulse on a T wave that could stop everything altogether.